Bismillah ar-Rahman ar-Rahim. My name is Dr. Amal Albeihany. I am a consultant adult hematology and bone marrow transplant. I am the vice president of Saudi Society for Blood Disorders. And on behalf of the society, I would like to welcome you all in our series of webinar, and specifically for the MENA Forum for Challenges in Hematology 2020. And this series or the MENA Forum were organized starting from the 7th of September to the 29th of March, and it will be held every last Monday of each month. And as it's said in the name there, it targeted the challenges in hematology, like things that not very commonly touched on or come through. So during that, we will have topics like Langerhans cell histiocytosis, which was held previously. And today we'll be having the Waldenström management, then plasma cell disorders, amyloidosis management, and graft versus host disease. And that will be every Monday, as I mentioned, and this will be covered by our national and international eminent speakers who have the lead in these topics. And I have the pleasure to thank our platinum sponsor, Johnson, for this forum, and Al-Hikma as well for gold sponsor for these webinars. Today, our topic, as I mentioned, will be about the Waldenström management, and we'll have three speakers, Professor Troen and Dr. Ramesh Pandita and Dr. Imran Tailor. And this is the program. So we'll start with the presentation of Dr. Troen, followed by question and answer, and then we'll have one case by Dr. Ramesh Pandita and another case by Dr. Imran Tailor. And then we will have a discussion with the whole panel where the cases as well. So as usual, you will find our webinars fully recording and you can access that after the meeting through our social areas. Area, and he has more than 300 peer publication in peer-reviewed journals, and he is a principal and organizer for many workshops in that regard, and he has many honors in the ASH as the best presentation, and now he is leading a study also for the effect of during the area of the COVID-19 for the effect of BTK inhibitors as well on the COVID-19. So please, Professor Troen, the stage is yours. You can share your slide.
Thank you so much for that very kind introduction. It is really a pleasure and a real privilege for me to be part of this program today. And I believe now you're able to see my slides. I just wanted to confirm that with you.
Yes, it's clear.
Great. So to begin off with, this is Jan Waldenström that you're seeing here in the picture. He was, of course, a very important figure in medicine in the 20th century, not only having described Waldenstrom's macroglobulinemia as we know it, but also he contributed to our understanding of porphyria as well as describing carcinoid syndrome. So he really was a true giant in his time. These are my disclosures. And I think what I'd like to do is just start off a little bit talking about the diagnosis of Waldenstrom's macroglobulinemia. This is a lymphoma classified under the WH criteria as lymphoplasmacytic lymphoma. and important to keep in mind that it accompanies the production of an IgM monoclonal protein of any concentration. And this is important to keep in mind because many times patients can present with very little, IgM levels.
Dr. Troen,
Yes?
just sorry for interruption. It's showing the desktop now. Can you reshare from the PowerPoint?
Yes, yes. Let me try one more time. That's odd. Let me just stop again and do share. Can you see the?
Yes, now perfectly. Just the slideshow, and it will be maximized. Thanks.
Perfect, perfect. Thank you. As long as you can see, because it's more important for you to see it than me. So, thank you.
But now we can see the split screen, not the full screen.
You can't see, now you're seeing the split screen. Okay, which makes that odd too. Give me one moment because sometimes it gives me, you're able to see now. Okay.
Just press the display setting on the top.
Display. Okay.
Setting. On the split screen, you'll find at the above display settings.
I don't know why it's not allowing me. I think at the top here we're supposed to, because it's maybe the platform is the issue here.
Just press the display setting in the up.
When you say
it's in the middle, Dr. Troen. In the middle, on the top side.
Oh, this is on the, okay, hold on one second. So this is actually on the actual program I have with you. All right, let me see why that's not coming up. Show grid video, okay. Which I've done, thumbnail. All right, guys, I'm still struggling with this. So when I look at the Zoom, is that where you want me to be to hit display?
Yeah, you have this. I'm sure you are using two screens. So
yes, I am.
Yeah, share your screen.
So I'm going to do share screen now again. I'm going to hit screen 2, which is where my presentation is, or how do you want this to work?
Yeah.
And then I may have to look at that instead of you, but I guess that's okay,
yes,
right?
Yeah. Now we can see it. Perfect. Yeah.
You can see it. Okay. So let's just make sure we can get this going. So I think it's important for people to keep in mind that any IgM concentration can help make the diagnosis, and the typical markers of CD19, CD20 will be present. Now, we're going to talk a little bit about the diagnostic testing for MYD88 and CXCR4, and this is where I think the ability to make the diagnosis correctly lies in having those mutations, because there are many other diseases that secrete IgM where you can have this difficulty in making the diagnosis, but MYD88 and having CXCR4 can be very, very important. Now, keep in mind the way patients present with Waldenström can be very different. Even though this is a lymphoma at time of diagnosis, only about 20% or less of patients have enlarged lymph nodes, but later in the course of disease, it becomes very, very common. The bone marrow is impacted in all the patients. You can have anemia as the most critical finding, but keep in mind anemia can be caused by many other mechanisms too. One of the most important ones that we discovered is that the Waldenström cells make hepcidin, and hepcidin blocks iron from being taken up by the gut. And it also causes monocytes and macrophages to take in the iron and hold on to it. So even if you stain a bone marrow for iron, you're going to find it in the bone marrow, but you have to be really careful. When you look at the cells that actually have it, it's the monocytes and macrophages, not the erythrocytes. We do see other manifestations, other cytopenias, but more rarely. Now, many of the patients present to us because they make a lot of IgM. The IgM can be a problem, the monoclonal IgM. It can cause hyperviscosity. We may be hearing about a case later today. Typically, this occurs when your IgM is above 6,000 milligrams per deciliter or 60 grams, per liter. Waldenstrom, cryoglobulinemia can also be caused by the IgM. A lot of the patients now are presenting with IgM neuropathy because the neurologists are working them up and doing serum protein electrophoresis. And amyloidosis also tends to occur in about 10 to 15% of patients, but usually later in the course. The one thing I just want to talk a little bit about is Bing-Neel syndrome. This is when the disease gets into the CNS. This used to be very rare, but now actually we see a lot of cases because as the patients are living longer, this has become a frequent site of relapse. And you'll see during my presentation how the treatment of this has dramatically changed. Now, the NCCN has very straightforward guidelines, which I would refer you to as to when it's appropriate to treat a patient as opposed to watch and wait. So keep these criteria in mind. Now, traditionally, we've treated Waldenström's by using Rituxan-based therapy. With rituximab alone, you tend to see response rates of about 30 to 40%. You never get really deep responses, and progression usually occurs in about 1 to 2 years' time for those patients that respond. Because Rituxan only covers part of the clone, the mature B cells, it was really important to help identify other therapeutics that can synergize with Rituxan that also cover plasma cells. And this led us to proteasome inhibitors, as well as bendamustine, where you see response rates of up to 90%. But CRs are still very, very uncommon. But even with this, you can see 4 to 6 years of progression-free survival averages with bendamustine or with a proteasome inhibitor like bortezomib. Now, many of these drugs also have critical side effects, which is why we are still working hard to identify new drugs. With rituximab, you can see this flare in about half of all patients where the IgM can go up abruptly, and this can lead to hyperviscosity crisis, particularly for people that have high IgM levels. But you can also imagine that if anything else is connected to the IgM, peripheral neuropathy, cold agglutinins, cryoglobulins, you can make this worse. And intolerance to the Rituxan also occurs with time. People become allergic to it, so we often switch over to ofatumumab. Fludarabine we used to use a lot of, but we saw a very high number of transformation cases. Bendamustine, we can see both MDS and acute leukemia more uncommonly with 6 cycles as opposed to 4 cycles. And you can also get prolonged cytopenias, which is why we tend to minimize its use in younger patients. And bortezomib, we tend to see a lot of neuropathy, more than we see even in myeloma, and high discontinuation, which is why we're exploring second-generation drugs like carfilzomib and ixazomib. Now, we already heard from Dr. Albeihany, who gave us a very nice prelude to the mutations in Waldenstrom. This was the one we discovered and described in the New England Journal back in 2012, which was a single nucleotide substitution at position 3 at chromosome 3p22.2 that led to this change in leucine for proline at position 265. And we have now confirmed this mutation in up to 95 to 97% of Waldenstrom's patients. So it's almost pathognomonic of Waldenstrom's, although you can see this mutation even in other B-cell malignancies, which is how we use in context with the WHO pathology criteria. The second mutation involves CXCR4. This is a receptor which binds to CXCL12. And the mutations almost always occur here in the C-terminal domain. It's important to understand that there are 2 types of classes of mutations. The nonsense, where a stop codon is introduced. This most common one is the serine 338X. X means a stop codon got introduced, so everything after that was deleted. And there's also the frame shift mutations, where you have either insertions or deletions which scramble the protein code. Both of these change the characteristic of the CXCR4 mutation, and this is an area where a lot of regulators bind and inactivate the signal that's transmitted by binding of CXCL12. So if you scramble this area or delete it, you're not going to have those downstream deactivators occur. And this is why this is actually an activating mutation. And we see it in up to 40% of Waldenström patients. I'll talk to you about the significance in just one second. Important to keep in mind that the way patients present can be impacted by which mutation they carry. I'll go all the way to the end here. If they're MYD88 wild type, they tend to have very low amount of disease in their bone marrow, and they tend to not be sensitive to BTK inhibitors. I'll show you that in just a second. If they have the MYD88 mutation, then it makes a difference if they're carrying CXCR4 or not. But the one I want to come to, because we'll talk about this, is the patients that have the MYD88 mutation, but also carry CXCR4 nonsense, the ones that actually delete part of the tail. These are the patients that are going to present with hyperviscosity syndrome. They're going to have very high IgMs, a lot of bone marrow involvement. So keep this in mind, because we're going to talk about one of the cases hopefully later on in this program. Now, what are the prognostic impacts of these mutations? Well, if you have the MYD88 mutation, whether you have CXCR4 or not, it's a good thing. The ones that have no MYD88 mutation have poor survival and tend to transform to an aggressive lymphoma. And this is because the underlying genomics that they have are very much overlapping with many of those that have been described in ABC, DLBCL. They also are NF-kappa B activating, but below BTK, which is why the BTK inhibitors are not as active. So keep that in mind, that if you have somebody who presents and you can't identify the MYD88 mutation, make sure, first of all, it's not another disease. IgM myeloma can often be confused because they don't have MYD88 mutations. And what you'll see is that these patients will be at higher risk of transformation, and typically we use drugs like bendamustine or proteasome inhibitors to treat them, not BTK inhibitors. So let me talk to you a little bit about MYD88. This is a mutation that's found in the toll receptor pathway. Normally, TLRs are sensors for bacteria and for viruses, including COVID-19. I'll have one slide to talk about that in a moment. But when you have the MYD88 mutation, no longer do you need the receptor for signaling. In Waldenstrom's, we said 95% plus of patients have a MYD88 mutation. And what this does actually is it triggers these two molecules, most importantly, BTK. We discovered this in our laboratory, and this feeds into NF-kappa B pro-survival signaling. We also discovered in our laboratory that this other SRC family member is upregulated, and this is what turns on BTK as well as ERK and AKT, also contributing to pro-survival signaling. ERK actually contributes to inflammatory cytokine production. And why we should all get a little excited about this is because obviously we have BTK inhibitors, but some of these BTK inhibitors like ibrutinib and zanubrutinib also bind to and silence HCK at pharmacologically achievable levels, which is why we've been very interested in the use of drugs that target these particular proteins. So a little lesson on CXCR4. I mentioned this is a receptor. It binds for CXCL12 or stromal-derived factor 1. It's made by the bone marrow stroma. So this is an interesting molecule because it actually homes cells towards the bone marrow stroma. And this is why we see in the patients that have the CXCR4 mutations a lot of bone marrow disease. But also the downstream signaling actually turns on molecules that produce drug resistance, especially to BTK inhibitors and certain proteasome inhibitors, which is why we've been very interested in blocking CXCR4 as a way to overcome drug resistance. I'll talk to you a little bit about that towards the end. Now, this is an update that just got published in JCO. The original paper was published in the New England Journal of Medicine by us, looking at the activity of ibrutinib in previously treated patients. The overall response rate in these patients was 90%. 80% had a major response, 30% VGPR, very good partial response. But depending on what their genomics were, you see a big difference. If you have MYD88 alone, very high response rate, very high VGPR, which is 90% reduction in disease burden, very quick time to major response. But if you have both mutations, you see that the major response rate goes down, especially VGPR, and it takes a little longer to respond. Nonetheless, very good numbers because these are, heavily pretreated patients we're talking about. But if you're wild type for MYD88, meaning no MYD88 mutation, you see no major responses, which is why the genomics become very important. And also, when you look at how the patients did long-term, 54% still had not reached, their progression status. 87% were still alive, but it made a big difference what the mutation status was, especially if they had only the MYD88 mutation. If they had both, the average median PFS was about 4 years' time, so still very good. But 75% of the patients who only had MYD88 were progression-free at 5 years, and you see how quickly the patients who had no MYD88 mutation progressed. These are the long-term toxicity findings. The thing to keep in mind is we did see more atrial fibrillation with the long-term follow-up. It went from 5% to 12.7%. But keep in mind, almost all the patients remained on ibrutinib with medical management for their atrial fibrillation. I think this is very important to keep in mind. Now, as a follow-up to this initial study, there was the INNOVATE study, where patients were randomized in 9 countries to either get ibrutinib and Rituxan or placebo plus Rituxan. And this was a very interesting study because it did show that if you use both drugs together, ibrutinib and Rituxan, you got very high, overall and major responses compared to Rituxan alone. And you did still see some differences, with mutation status. If you had the CXCR4 mutation, which I just showed you, lower major responses, VGPR, but the time to get to one of those responses was almost the same as those patients that only had the MYD88 mutation alone. Now, this shows you progression-free survival. No surprise it was better for ibrutinib and Rituxan versus Rituxan alone. But the patients that actually had the CXCR4 mutation showed earlier progression than the patients that did not. So this is why we still remain very active in trying to find a way to overcome CXCR4 mutations. Now, just one quick word about Bing-Neill syndrome. We used to hospitalize these patients and treat them with high-dose methotrexate. These days, we just give them, ibrutinib. And we try to give them the higher dose ibrutinib at 560 that we showed in one of our earlier studies actually produces good CSF levels of the drug. This was really one of our worst cases of Bing-Neill syndrome. You can see from the MRI, the parenchymal disease, PET-CT lighting up the brain parenchyma, and just a few months later, how much things had changed for this patient. So we've subsequently published a follow-up paper, my colleague, Dr. Castillo, alluding to, multi-center experience now with ibrutinib showing activity, even at 420 once a day for these patients. Now, in addition to ibrutinib, we've also been looking at other BTK inhibitors in our field, acalabrutinib, zanubrutinib, tirabrutinib. These are drugs that have different kinase profiles, which can either add to the activity or cause side effects, which is why each one of these drugs have been looked at in Waldenstrom's disease. The acalabrutinib study was reported earlier this year. It involved both treatment-naive and previously treated patients. It was a large phase 2. The drug here is given twice a day, 100 milligrams twice a day. And with the follow-up of about 2 years' time, the progression-free survival was about what we had seen with ibrutinib overall, as were also the response rates. The side effect profile, interestingly, mirrors very much that of ibrutinib, except patients can get headaches in those few months, but then they subside. The AFib rate with the 2-year follow-up was 5%, which is about where it was for ibrutinib. But over time, it'll be interesting to see if AFib rates go up. No atrial fibrillation event led to acalabrutinib being withheld or discontinued in this study. Now, you also probably have heard about the ASPEN study. This is a direct head-on study of zanubrutinib versus ibrutinib. which was just reported in Blood. So this paper is now out. And the overall response was the overall response attainment, particularly the VGPR-CR was the primary endpoint of this study. Unfortunately, this was not statistically significant, but follow-up will be needed to see if this actually changes. And they had some data in the paper that suggests that might be the case. But what VGPR means in Waldenström's with a BTK inhibitor still remains to be clarified. So it'll be interesting to see. The one that I thought very interesting in the study is they did do a post-hoc analysis using next generation sequencing for CXCR4. And just look at this here. For both zanubrutinib and ibrutinib, if the patient was CXCR4 mutated, it was a lower VGPR rate compared to wild type. So very much affirming what we had found about the impact of CXCR4, but also seeing it now with zanubrutinib as well, which is why, again, we're interested in now blocking CXCR4, but I'll come to that in a second. There were some differences in the adverse events. The atrial fibrillation difference was actually quite interesting here, much less for zanubrutinib. But conversely, there were more neutropenia events associated with zanubrutinib. And this may have to do with the fact that zanubrutinib is given twice a day in this study, compared to once a day with ibrutinib. So we'll have to see, in due time why there's more neutropenia events. They tend to be more common in the previously treated patients than the frontline patients. But this does show you that these BTK inhibitors can behave differently, which is why long-term experience is going to be needed for us to better understand how to use each one of these in the right context. Now, I just want to talk a little bit about venetoclax. This is also a very, very active drug in Waldenström's. This is a multi-center study that we've been running. The overall response rate was 90%. 83% of patients had a major response in the study with about 18 months of follow-up. But look at the bone marrow difference. You can see a very rapid reduction in bone marrow clearance, much better than we even have seen with ibrutinib. And the 18-month PFS was 82%. These are the progression-free survival data. Important to keep in mind whether the patient had or did not have a prior BTK inhibitor, the drug was active, which is why now we're combining ibrutinib with venetoclax in treatment-naive patients in one of our frontline studies. My colleague, Dr. Castillo, is running this, but we're very excited about this study given what we have learned about each drug individually and the potential to synergize. Now, CXCR4, we have concluded this trial. It's a very positive one. We'll be submitting it for publication very shortly. But here we used ulocuplimab, which is a CXCR4 blocking antibody, along with ibrutinib. And we treated patients for the first 6 months. We have seen very deep responses, the same that we see with CXCR4 wild-type patients. So we're excited about the outcome of this trial, except that ulocuplimab has been discontinued by BMS for commercial reasons. They didn't see a signal in AML in one of their studies. So we need now another solution. And the one that we're focusing on now is the drug mavorixafor. This is a new drug, but it's built on the same platform as plerixafor by the same developers, in fact, but it's now an oral drug. And we use plerixafor, as you know, for mobilizing stem cells. So mavorixafor is a blocker of CXCR4 stimulation by CXCL12, and we just started this trial. It's a very exciting trial combining mavorixafor and ibrutinib in CXCR4 mutated patients. So I think we're going to have the ability for an all-oral therapy going forward once we know how this trial performs. These are recommendations on how to use both MYD88 and CXCR4 to make genomically based treatment decisions. This was published in JCO earlier this year by us. I think it's important just to keep in mind that, the drugs that actually have shown the greatest activity level for the MYD88 mutated patients alone have been the BTK inhibitors, which is why we prioritize these for the MYD88 mutated only patients. If they're dual mutated, we want to make sure you don't need a rapid response. So somebody who has, let's say, the nonsense CXCR4 mutation might be somebody presenting with a hyperviscosity crisis. in which case you always want to do plasmapheresis first. And maybe here, bendamustine or bortezomib-based therapy may be better, because with ibrutinib, you see a delay of like 5 months on average to get a response. But if you don't need a rapid response, you can either think about BTK inhibitor plus rituximab. And the patients that are MYD88 wild type, we would avoid BTK inhibitors because you know, they don't really show the level of activity that I think we want. So here, bendamustine or proteasome inhibitor can be considered. We tend to prioritize bendamustine for people with large lymph nodes or extramedullary disease, and proteasome inhibitors, particularly for amyloidosis, in which case we may also consider autotransplant as a consolidation. In the previously treated setting, I think much the same as the way we would think, prioritizing again BTK inhibitor if they haven't seen one, but also keeping in mind that venetoclax is also an option for these patients. And autotransplants we tend to consider in people with multiple relapses, but they have to show chemo-sensitive disease, because the autotransplants don't really work in people that have chemo-refractory disease. Just one quick word about COVID. You know, there's, you know, obviously been a lot of concern early on about how patients who are on BTK inhibitors would do if they contracted COVID-19. We were the first to actually publish this paper that appeared in Blood on April 16. It occurred when we were having this very high number of COVID cases here in the Northeast. And this actually was a very interesting study. We learned from this that patients that were on full dose ibrutinib and had been on it for Waldenstrom's, you know, for quite a few months, as you can see here, actually did very well. They may have gotten the cough and fever associated with COVID, but no one got really the dyspnea or required oxygenation. And their course actually was fairly mild. I mean, they actually did well and resolved fairly quickly. But there was one patient, number 6, that taught us the most. It was a patient who had been already on decreased dose of ibrutinib because of arthralgias, and he was on 140 of the drug. And when you went and saw his primary oncologist locally, they held his ibrutinib because they were concerned about immunosuppression. And during this time, he became very short of breath, ended up in the hospital. He got tried on hydrochloroquine and azithromycin, which at the beginning of the pandemic, if you remember, a lot of people were being tried on these. Tosatuzumab, the anti-IL-6 antibody, was tried. But despite this, his course was failing. He went on mechanical ventilation and was not doing well. When we decided, because of everything that we had seen, to put him on full dose ibrutinib. And once we did that, within 24 hours, he was extubated. 24 hours later, he had no oxygen need and was discharged home. And this is what prompted us to now initiate 2 clinical trials, one with ibrutinib, the other with zanubrutinib, looking at the activity in patients with pulmonary distress with COVID-19. These are healthy patients that had no malignancy who contracted COVID-19. And there's also a trial looking at acalabrutinib. And you may have seen also other papers in CLL patients, as well as showing potential benefit of ibrutinib, and also a study on acalabrutinib as well with potential beneficial effects. This study was also very important because it also provided guidance to maintaining patients on ibrutinib as opposed to discontinuing the drug during the pandemic. And now a lot of the guidelines continue to recommend or even prioritize ibrutinib over chemoimmunotherapy. But I think this is really important to share with you. So at this point in time, first of all, I want to thank you for listening. It's really a privilege for me. I have had wonderful collaborations over the years in sharing patients with many members there of the Saudi Society. And I'm happy to take any questions at this point. I also have a couple of cases, but I also know that Dr. Pandita also has a case for us. So I will leave it to you to let me know how we should go. Perhaps Dr. Albeihany can provide us with her insights, and whether we should do Q&A at this point, talk a few cases, or go right to Dr. Pandita's case.
Thanks a lot for the really excellent, informative presentation. I think we are on time, and we can take a question and answer later with some discussion, and then we will take the cases. So the first question is from Dr. Saud Al-Haili. In multiple relapse cases and planning for auto stem cell transplant, what chemotherapy do you use to show chemosensitivity?
No, I think this is a good question. You know, ordinarily what we do is we refer back to the recommended treatment approaches, you know, that we have in the NCCN guidelines. And so, you know, there is really no quote unquote standard of care that exists in the frontline setting. It's very patient dependent. In younger patients, we tend to avoid alkylators. So we'll either prioritize a BTK inhibitor or we'll use a proteasome inhibitor. In older patients, and you know, what old is changes every day. You know, it depends on how old the oncologist is. But, you know, if we start seeing patients in their late 60s and 70s, you know, we will start using bendamustine. We'll tend to limit it to 4 cycles of therapy if possible, because our retrospective studies show very similar effect, you know, for 4 versus 6 cycles. And so we tend to just minimize alkylator use in younger patients. The exception being that if they present with bulky disease, then we will, you know, prioritize the use of a bendamustine, you know, based regimen. Keep in mind that we always hold Rituxan for people that have high IgM levels and usually above 40 grams per liter or 4,000 milligrams per deciliter. We will hold the Rituxan so we don't have a flare complication. But in general, to think about auto transplant, those would be the options that we would consider first, either a BTK inhibitor, proteasome inhibitor, or bendamustine. Also, in all honesty, the more therapy, you know, that the patient sees, the less effective auto transplant is going to be, especially above 3, you know, prior regimens. So if you're going to consider it, you should consider it, you know, before 3, but it should be somebody with chemosensitive disease. Now, here's the issue. Keep in mind that the data that we have from the EBMT doesn't really suggest an advantage for auto transplants over BTK inhibitors. In fact, the median PFS was about 5 years, and about 8 to 10% of patients had, you know, mortality that was non-relapse related and related to myelodysplasia in many of those cases, which is why that if you're thinking about somebody who's in the relapse setting and or refractory setting, you should try a BTK inhibitor before you think about auto transplant.
Let's come to one of the other questions. I think, do you think bone marrow transplant work or you prefer the targeted therapy?
There's no question what I prefer. It's targeted therapy first. And, you know, in our clinic, very few patients, you know, do we ever transplant. We try to take an approach where using targeted therapy, you know, over, you know, therapies that could potentially create risk for the patient, particularly myelodysplasia and secondary leukemias, you know, being our biggest concern, transformation of disease with nucleoside analogs as well. We tend to be risk aversive. And I think this is why we have seen this tremendous change in mortality associated with this disease, because not only are we using better drugs, targeted drugs, but we're also not using drugs that otherwise would have created you know, problems like secondary cancers.
So next question is, if patient was treated with bendamustine rituximab and achieved PR or VGPR, do you stop therapy if they still have IgM detected and become asymptomatic, or you shift to other type of therapy?
This is a fantastic question. I thank whoever asked it. the goal of therapy in Waldenstrom's is to eliminate the symptoms that caused you to treat the patient. So your goal shouldn't be a CR. It should be to get the patient asymptomatic. One of the common questions is around the use of maintenance Rituxan. Should I use it or not in somebody who got a Rituxan-based regimen? And, in our practice, we tend to use maintenance Rituxan. Anybody who has at least a minor response or better will consider it. We usually give 1 infusion of Rituxan every 3 months for up to 2 years. However, be very careful because, the IgG and IgA levels can go down and the patient can then develop, recurring sinus and bronchial infections. So if you do see a patient like this that you want to consider maintenance Rituxan, just follow their IgA and IgG levels, to be able to better understand, and ask them about sinus and bronchial infections. And I would, be very quick to stop if you see the IgG levels coming down. And IgA is low in most of these patients anyway, so you don't want to really make things worse. Now, at this past ASH meeting, ASH 2019, the Germans presented their maintenance Rituxan data, and this was a prospective study. Previous to that, we had published a retrospective study where if you had an MR or better, minor response or better, we wanted to see how you did with maintenance Rituxan. And in fact, these patients did better. They had better progression-free survival almost by 2 years if they were on maintenance Rituxan. The German study was prospective, but they used bendamustine, based therapy, and you had to have a major response or better to go into the study, to be randomized. And there they showed that overall, there was no difference in outcome except for older patients, 65 or older, or those that had high-risk disease measured by the IPSS score, in which case they had an advantage in progression-free survival. So I would think for somebody who is responding to a Rituxan-based regimen, we can learn from this experience and try to consider maintenance Rituxan.
Keep some of the question to the end, and some of the thanks again for actually enjoyable and excellent presentation. And we'll move to our next speaker, Dr. Ramesh. Dr. Ramesh is a consultant hematology at Kuwait Cancer Control Center in Kuwait, and he's a clinical tutor in hematology and Faculty of Medicine. He graduated from University of Kashmir in India in 1977, and he's a member of many society, and he has many publications in many peer-reviewed journals. He will present to us one of the interesting cases regarding the Waldenström. So please, Dr. Ramesh.
Thank you, Dr. Amal, for a kind introduction. In fact, I would rather will present 2 cases rather than one, and they're going to be a little more pedestrian, but they are what you see most of the time in the clinics. So this is what you are going to see. So that's what we are going to discuss here. So my first case was a 60-year-old male who came to us in January 2018. He came with dizziness. He had a swelling of feet. He was pale, and he had bilateral axillary lymphadenopathy, multiple, but relatively small at 1 centimeter in diameter, and a just palpable spleen. And his investigation showed him to have hemoglobin of 56. His platelet white cell count and differential were normal. And his serum chemistry showed very high total protein of 122 grams. And his albumin was low. His calcium was rather borderline, but pertinently, his LDH was normal, and the rest of the serum chemistry was also normal. What we found is his coagulation profile was normal. His serum B12, folate, and iron profile were normal. 24 hours urinary protein, urine protein electrophoresis also normal. His serum protein electrophoresis showed an M band of 66.9 grams per liter. Immunofixation electrophoresis identified it as an IgM kappa monoclonal band. Immunoglobulin profile showed low IgG and IgA, and his IgM was remarkably 96 grams per liter. Serum-free light chain, kappa lambda, as well as the ratio were normal, and beta 2 microglobulin was elevated at 5.7. His skeletal survey showed no lytic lesions, but his chest, his abdomen CT showed multiple lymph nodes in the neck, in the axilla, in the mediastinum hilum, and in the abdominal cavity post hepatic, portahepatic, mesenteric, retrocaval lymph nodes. So spleen and liver were also mildly enlarged. A bone marrow aspirate done in him showed 40% mature lymphocytes, including plasmacytoid lymphocytes, and 9% plasma cells. And his bone marrow showed interstitial and nodular infiltration by lymphocytes, plasmacytoid lymphocytes, and by few plasma cells. His cytogenetics was deployed. He had his viral markers we showed were negative for anti-ICV and hepatitis B as well as HIV. So he was diagnosed as Waldenstrom's macroglobulinemia. For the change, we used the revised IPSS for him, which showed an immediate risk, Waldenstrom's macroglobulinemia. So what we chose for him was that we actually had a fundoscopy done, but that didn't show any telltale signs according to our ophthalmologist for hyperviscosity. So, but still, because the IgM was so high, so we had a plasmapheresis. We had 3 sessions, and this was followed by bortezomib plus dexamethasone, where our plan was actually to give bortezomib, dexamethasone, and rituximab, but rituximab was omitted because of high IgM. Post cycle 1, his hemoglobin improved. Now he didn't need transfusion. His hemoglobin was 87, but his IgM was still high, 54. So he received cycle 2, and after cycle 2, hemoglobin marginally improved to 92, but IgM still remained high. And so we had to continue with the bortezomib, dexamethasone without rituximab. So in the 4th cycle, I decided actually better to have a plasmapheresis so that we can get in with rituximab, so we might get a better response, and we did. So we gave actually 3 more cycles that had its own issues later, but that we'll see. So, but what happened is hemoglobin improved, IgM dropped and stayed steady at 24. So here a partial response, and adverse events was a neutropenia, which happened rather late after the cycle 6, which responded to GCSF, and his counts came back to normal and stayed there. And his peripheral neuropathy was grade 2 with pain, which was post cycle 6. During his bortezomib therapy or BDR regimen, he did not get it. But once we had stopped the therapy, he actually got a painful grade 2 neuropathy. So we followed him up. His hemoglobin subsequently improved to 138. As I said, IgM stabilized at 28, generally between 24 and 28. And his M band also stayed back around 14 to 16 grams. So his peripheral neuropathy improved to just mild paresthesia, as he no longer has pain. Maintenance rituximab was not given because of low IgG and IgA. He was last followed up virtually, actually, by me about 2 months back. So what do you think was a challenge in this? What we thought rather was a challenge. This was persistently very high IgM, precluding administration of rituximab in the initial cycles of chemotherapy. So the question is how to choose appropriate chemoimmunotherapy, or what would, second question be question would be, what would be the current optimal therapy in such a patient? I will leave this to discussion, and I will go to the second case. So I generate some more questions for the second case. Second case was a 54-year-old, was a 54-year-old gentleman who presented to us actually way back in the department.
Pandita, do you think we should talk about the case first, or about this
Sure,
one?
we can interrupt it. We can interrupt it. Yeah, sure.
I think after we finish, we can discuss better. So we'll keep the question at the end of the second case.
Okay.
Okay.
So the second case is came to our department in June 2006, 54-year-old at that point in time, was type 2 diabetic, hypertensive, dyslipidemic, and a beta thalassemia minor. He had easy fatigability. He was pale, but had no palpable lymph nodes, no palpable hepatosplenomegaly. His blood counts showed a hemoglobin of 71. Platelets were normal, but which cell count was elevated at 29.3, and he had circulating small as well as plasmacytoid lymphocytes in the peripheral blood. His serum chemistry showed a total protein of 6 and an albumin of 31. The rest investigations were normal. His SP-EP showed an M band of 43 grams. IFE showed it to be an IgM lambda. And immunoglobulin, interestingly, his IgG was rather 17, but IgM was 43.2. Beta-2 microglobulin was 5. And he had a CT chest abdomen, mildly enlarged liver spleen, but no lymph nodes. Bone marrow aspiration biopsy showed around 80% infiltration by mature lymphocytes, plasmacytoid lymphocytes, and few plasma cells. So the diagnosis was Waldenstrom's macroglobulinemia. Started on one cycle of chlorambucil way back in 2006. He traveled abroad. He came back actually something like 3.5 years later in January 2010, and he had received treatment abroad, probably the same therapy for a year. He had returned to us for consideration of use of Revlimid or lenalidomide for this patient. So when we saw him clinically, we did not see any or hepatosplenomegaly. His hemoglobin was 105, and his protein was normal. He had an M band, but it was not quantified. But IgM 10.2, serum ferritin was normal, and we reconfirmed that he had a beta thalassemia minor. A bone marrow at this point in time showed lymphocytes only 18.6%, and a biopsy few interstitial D lymphocytes. So we put him on watch and wait. And he was on regular follow-up, but he had a gradual asymptomatic increase in IgM paraprotein. In 5 years down the line, in January 2015, he was still asymptomatic clinically, and he had no lymphadenopathy, hepatosplenomegaly, but this time his hemoglobin dropped to 74 grams, and his protein increased to 102 with albumin of 25. His M band now was 39.1, and IgM had elevated to 55.7. So we did a CT chest, abdomen, and pelvis. We showed bilateral axillary mediastinal abdominal lymphadenopathy with mild wedging of T12. He was first given a plasmapheresis that started on RCD. First cycle rituximab was omitted because of high IgM. And the second cycle, when we started, he got severe allergy, hypotension, breathing problems, so it was not given any further. CD was continued. Ofatumab was requested, but could not be arranged. So actually continued on cyclophosphamide plus dexamethasone. And he had a partial response to this therapy and was kept on follow-up. About a year later, or a year and a half later, in August 2016, he came with shortness of breath, bilateral pedal edema. His hemoglobin was 69. His IgM was, his albumin was 28. IgM was 41. M band was 20. Serum free light chain ratio was normal. He refused bone marrow examination at this point in time and just told me that he doesn't want any more investigations. So we decided to give him ibrutinib 420 milligrams daily. He tolerated it well. 3 months, his hemoglobin became 114. His pre-treatment was actually 69. His IgM dropped to 18.6 from a pre-treatment 1.3. And M band dropped from 20.9 to 7.7. And when latest follow-up, which was virtual again on the 3rd of September of this year, he had no complaints. His hemoglobin was 96, marked you that this patient is a beta thalassemia minor. His IgM was 9.1, which is steady, and his M band was 6.9. So we continued him on ibrutinib, which will be now 48 months. So of course, we already have seen the answers to this to a large extent with that brilliant opening address. That was how to manage relapse Waldenstrom's macroglobulinemia, looking that it has a very indolent course. It can have a long course. With this, I get back to the question. Thank you for listening.
Thanks a lot, Dr. Ramesh, for concise to the time and interesting cases. For the attendees, please your question to the Q&A icon so we can receive them. So for the first case, Dr. Ramesh raised two points. So for the panel, we have Dr. Troen and Dr. Imran Tailor together with Dr. Ramesh. So the first question with the first case was how to choose on the chemoimmunotherapy for that patient. You can comment, Dr. Troen, on the case.
Thank you. Thank you for two excellent didactic cases, Dr. Pandita. I think the question that you asked and the challenge about, what do you do with somebody who has persistently high IgM levels, shouldn't surprise us. This case that you presented, somebody came in with very bad hyperviscosity. I was surprised that there were no findings in the eyes by exam, but many times I send these patients to the ophthalmologist where a good dilated exam, and when you look at the periphery, you can see hemorrhages, which may not be apparent during our normal, examination in the clinic. I would have liked to have known a little bit more whether the patient was dizzy, but if they were having any nosebleeds, anything else that might have, given us some sense of hyperviscosity syndrome. But this is probably the worst of the patients that you will ever see with Waldenstrom. Somebody coming in with very high IgM levels. They're symptomatic. Their genomics almost always show that they are CXCR4 nonsense mutated. And this is what's, contributing to this very large bone marrow involvement and high IgM production. So what you did in this case, I think, was textbook. You did a wonderful job working this patient up and treating them. Plasmapheresis is the correct, absolutely correct answer. It's a young patient, 60 years old, is still young. Probably would have been making some decision around whether to use bendamustine or proteasome inhibitor, depending upon the lymph node involvement. Proteasome inhibitors usually are not very good if somebody has, big lymph nodes. If they are not bulky, then I think it's reasonable to use a proteasome inhibitor because we do know the IgM goes down very, very quickly. But if this patient had bulky adenopathy, then I think I might have used, bendamustine as my initial approach to treating them. I think what Dr. Pandita did here with proteasome inhibitor was very, very appropriate because the lymph nodes sounded like they weren't bulky to begin off with. The use of the proteasome inhibitor with dexamethasone initially without Rituxan, I think, was also textbook. We avoid the use of Rituxan because otherwise you might stimulate the production of IgM, which I think would have made things worse. And some patients are brittle. It'll take a bit of time before the IgM gets down sufficiently, so you may have to support them with additional plasmapheresis, as Dr. Pandita did. I think in this case, this was a very well-handled case where you continued to treat the patient. Things that might have changed today are the type of proteasome inhibitor that you might have used and how you used it. I usually like in the first cycle or two for somebody who presents with severe hyperviscosity to give the bortezomib twice weekly, and then I go to weekly and we'll even use subcutaneous. Carfilzomib could have been an option as well. We do know that it's active in Waldenström, and now we also know that ixazomib is active, and both carfilzomib and ixazomib tend to have lower neuropathy risk. So these could be things that we have become a little bit more sensitized to, than just using bortezomib alone, today. This is also a patient I probably would not have used a BTK inhibitor because most likely genomics will show that this is somebody with a nonsense variant. and it would have taken some time to get this patient, under control. So again, I think Dr. Pandita, you handled this, textbook. I think you did everything for this patient that we would have done, given what you learned. I do have one or two questions to ask you about the case. And the first is, we saw the albumin level was low. I wonder if you were thinking about of amyloid in this case, and whether or not an amyloid workup was done, because the patient also had some edema, which might have implied either cardiac amyloid or kidney amyloid. I do know you did get a 24-hour urine that didn't show nephrotic range area.
Yeah, I can come in there. We had actually a cardiac evaluation. I think for brevity of presentation, I should have put it now. I put retrospectively.
Right.
We did have his echocardiography as well as actually a MUGA scan done on him, and both of them were normal. There was no restrictive cardiomyopathy. And second thing is, if I remember correctly, but I would have to think that his 24-hour urinary protein was probably in the normal range, was not certainly in the nephrotic range. But I am probably thinking from my memory. But we did have, I thought probably the amount of disease in itself probably led to some of hypoalbuminemia in this patient. Looking at the infiltration in the marrow, looking at also his IgM of 96. The question we had was why we chose this therapy primarily was for speed of response. And though we were afraid, initially we did actually use longer. I recall now that twice a week, a little longer. In fact, I referred to your how I treat myeloma. So you might have found that that's how it went. Because there you said that though it is better later, you found that to give weekly, but those people who have high and delayed response, you might give a little longer period, twice a week. So that's why we give it longer. And I feel to some extent we might have slightly added on, though we know he luckily recovered from neuropathy, so it's not a major issue. But yes, it might have. But we know even with weekly by Professor Dimiapoulos trial, they still had 40% nearly, I think, peripheral neuropathy, though grade 3 and more was only 7% in that weekly protocol. So I do agree, but he's done well thereafter. He hasn't shown any progression. We have seen him regularly for the last 2 years. I would have think otherwise an amyloid would probably show up by this time if he had.
I would think so. I had just a couple of more comments. I was very surprised how anemic this patient was. And again, you checked off all the right boxes here. You looked at the bone marrow. I presume you saw no evidence of MDS. You did an iron workup, which, very common when these patients are iron deficient. You reported that it was normal, and the rest of your anemia workup looked normal. Wonder if you were thinking at all about, either a cold agglutinemia or a warm antibody contributing to hemolysis. Your retic count was low, which surprises me, but I wonder if you had any other thoughts, because this patient was very, very anemic, even for the amount of disease they had.
Yeah, I did. We did have actually cold agglutinin was negative, but he had no evidence of hemolysis. So he had no retic count was normal. In fact, if we see his bilirubin was normal. So LDH wasn't very high, 112. So that would rather go against. Though I must say that he has Coombs was positive, but not hemolytic. So there was no hemolysis. So that's why I didn't have to create confusion here. But he had LDH was normal, bilirubin was normal, and his retic count was normal. So no hemolysis. Yeah. And with very high IgM, sometimes these phenomena do happen. Exactly. I don't think hemolytic anemia. I think his infiltration is very considerable.
We can move to the second presentation and the second case, and maybe we'll have raised question for both cases at the end of the discussion. So just because of the sake of time, thanks again, Dr. Ramesh. It's given me the pleasure now to present our third speaker for today, webinar. Dr. Imran Tailor is a consultant hematologist at the Department of Adult Hematology and BMT at King Fahd Medical City, Riyadh. He's working there since 2012, and he graduated from India, and he did his residency and fellowship at UK, and he did stem cell transplant fellowship at Sheffield. He is a fellow of Royal College of Physicians and fellow of Royal College of Pathologists. His areas of interest include lymphoma, myeloma, and stem cell transplant, and he will present for us another challenging case. So please, Dr. Imran, and please try to stick to time so we can have some time for this discussion.
Can you see my slide?
Yes, we do.
Yes, very nicely.
Thank you, Dr. Amal, for the kind presentation and fantastic talks by Professor Troen and very interesting cases by Dr. Ramesh. So today, I would like to thank SSBD and Dr. Faraz for the kind invitation. So we've been asked to share a case emphasizing on diagnostic aspects of Waldenstrom's macroglobulinemia. So I have a case who is a 74-year-old female now. When she presented, she was 68 in 2014 with past history of diabetes and hypertension. She presented with dizziness, tinnitus, headache, gum bleeding, and MENA for 3-4 weeks from a peripheral village in Saudi Arabia. She didn't have any fever, no history suggestive of peripheral neuropathy. Her vitals were stable, Glasgow Coma scale was 15. Exam did not reveal any lymphadenopathy or hepatosplenomegaly. There were no rash or ulcers. There was some mild edema. And we sent the samples, and the labs keep returning our samples saying the sample is clotting. So if you look at these labs, out of 15 samples, nearly 10 were rejected because they were clotting. So it's important whenever such things happen, we talk to the biochemist or one of the senior physicians. We managed to get the labs done. So finally, and hemoglobin, she was mildly anemic, white cell count and neutrophils were okay, lymphocytes were within normal range, platelets are normal, ESR was very high. Blood film didn't show any Rolo or any suggestion of cryoglobulin. There were no abnormal cells seen. PTA, PDT were marginally increased, fibrinogen was normal, LDH was normal, viral serology was negative, calcium was high, 2.74, total protein was 96 grams with albumin 28, sodium 130, hematinics were normal. So given this, we suspected the patient may have a cryoglobulin. We tested for cold agglutinins, it was negative. Combs was negative as well. There was no evidence of hemolysis. Retics were within normal range with total bilirubin normal. So this patient with high globulin and symptoms suggestive of hyperviscosity, blood clotting, we suspected Waldenstrom's in this situation. If you look at this slide, in a normal slide with normal protein or no cryoglobulin, it has a pinkish hue, whereas a patient with cryoglobulin, it can have a bluish hue. And also the serum protein electrophoresis showing M band here, and a blood film, a patient with cryoglobulin, you can see the bluish cryoglobulin, and there is no role of formation. And just a few words about cryoglobulinemia. So what is a cryoglobulin? It's an immunoglobulin that can precipitate with cold temperature and dissolves with warming. And there are 3 types, type 1, type 2, type 3. Type 1, you see in B lymphoproliferative disorders like Waldenstrom's due to monoclonal immunoglobulin, whereas type 2, type 3, you have both monoclonal and polyclonal or polyclonal. You see type 2 and type 3 primarily in autoimmune diseases, hepatitis C, and sometimes in some lymphomas as well. So when you have high cryoglobulin, it can cause vasculitis, causing Raynaud's phenomenon. Even cold agglutinins as well can cause Raynaud's phenomenon, but they don't cause ulcers or distal necrosis. And mixed cryoglobulinemia that we primarily see in rheumatological patients as vascular purpura, arthritis, and sometimes cryoglobulinic nephritis as well. So how do you assay cryoglobulins? You need to collect the sample in the pre-warmed tube without an anticoagulant and keep a temperature of 37 degrees plus or minus 2 degrees, and ideally collect the sample on site and transport to the processing lab immediately, maintaining the temperature plus or minus 2 degrees centigrade. Ideally, you should better to use a thermos to keep a temperature around 37. So how do they test for cryoglobulins? Incubate at 4 degrees for 7 days. So you can see on the right-hand side, after 7 days, you have got a precipitate, cryoprecipitate, and then you further type it with immunofixation and give a cryo percentage. So cryoglobulin can cause ulcers, you can see, and purpura in these figures. So our patient showed a monoclonal spike IgM 44 grams per liter with no immune paresis. Kappa was raised 5.35 with an abnormal ratio. 24-hour urine protein was normal, but there were no bench-Jones proteins. Plasma viscosity was normal. It was not correlating with his symptoms, which can happen. And even his fundoscopy, I should add, did not show any symptoms of hyperviscosity. But clinically, patient was showing symptoms. And the imaging also showed small volume generalized lymphadenopathy, except for mesenteric nodes, which were measuring up to 4 centimeters. Liver span was 20 centimeters, but there was no splenomegaly, no lytic lesion. So we did a marrow. It showed plasma cells 8% and lymphoplasmacytoid cells around 35%. The flow, 10% of the cells were positive for B cell markers, CD19, 20, 23, 22, HLA-DR, and kappa restricted, negative for CD5 and 10, and Troen showed interstitial and paratrabecular infiltration of lymphocytes and plasma cells, positive for CD38, 138, 20, and kappa. So it's already been discussed, definition of Waldenstrom's: any infiltration of clonal lymphoplasmacytic cells with any amount of IgM. The WHO criteria: there is no threshold for bone marrow clonal infiltration, but those with less than 10% have an indolent course. LPL without IgM is not Waldenstrom's, but it is just LPL. Patient can have LPL with IgG or IgA, but although biology may not differ much, IgM without LPL histopathology is not Waldenstrom's, or LPL without IgM, but IgM, MGUS, or nodal lymphoma. So somebody who has IgM, but no lymphoplasmacytic lymphoma histopathology, so it could be IgM, MGUS, or a nodal lymphoma. So patient not fulfilling the Waldenstrom's criteria can still have IgM-related complications. So patient may still need sometimes treatment or those questions to be answered. So looking at the morphology, so you can see here in the bone marrow Troen, plasmacytoid cells with clumped chromatin. And also you can see a lymph node here with diffuse infiltration, even with extracapsular extension. And this is another slide showing lymph node diffuse infiltration with lymphoplasmacytoid cells. And you can sometimes see immunoglobulin nuclear inclusion bodies, or Dutcher bodies, or what we say. So classically, you have interstitial infiltration in Waldenstrom's macroglobulinemia. So here you can see paratrabecular and interstitial infiltration of plasmacytoid lymphocytes. The classical immunophenotype in Waldenstrom's always express surface immunoglobulin, CD19, 20, 22, 79, usually express 25, 27, FMC7, BCL2, rarely 5 and 10, 23. So you have small population of plasma cells that are CD138 positive. They have an immunophenotypic overlap with B cells, not that of myeloma. So they're often positive for CD19, 45, 27, and 81, but negative for CD56. In myeloma, usually they are negative for CD19 or positive for CD56. So you can look at the immunohistochemistry in Waldenstrom, CD20 strongly positive, and IgM, and again, monoclonal surface light chain restriction, CD138 positivity and CD38 positivity you can see here. And sometimes you can see active mast cells. And as you can see, background of plasmacytoid lymphocytes with some dark blue cells, which are mast cells. And they're positive for CD117 and mast cell tryptase, but they're negative for CD2 and 25. Whereas the neoplastic mast cells would be positive for CD2 and 25. So our patient, the fish was negative for 17p deletion, 1114, 414, the limited panel we do, but karyotype unfortunately failed, and mid-88 was not done at that time. We didn't have access to. So we made a diagnosis of symptomatic LPL with IgM or Waldenstrom's, given his typical symptoms, typical flow, and hyperviscosity symptoms and adenopathy. So coming to cytogenetics in Waldenstrom's, you have deletion 6q in 30 to 50% of the patients, which is absent in IgM-MGUS, and translocations involving IgH are absent that help to distinguish from myeloma. Coming to molecular characteristics, this was a seminal paper from Professor Troen, published in New England Journal in 2012. So 70 to 90%, but as we heard from Professor Troen, up to 95% of the patients could have positive mid-88, probably depending on the sensitivity of the test you use or the sample you take from a bone marrow or peripheral blood. And CXCR4 mutations are found in 20 to 40% of the patients.
Imran,
there's a blend.
the case, please, just because of time. Yes.
Okay, yeah. So just other diagnostic assays one should consider is Raynaud's phenomenal dysfunction, evaluation of cryoglobulins, and look for hemolytic anemia, which we didn't have in our case. Serum viscosity was okay. We looked for von Willebrand's and factor 10 as well, that was negative. And we looked for 24-hour urine protein and cardiac assay negative. So unlike patient had amyloidosis, she didn't have peripheral neuropathy, but if you have peripheral neuropathy, one should send for myelin-associated globulin antibodies and antiganglioside antibodies as well. So central nervous system involvement, Bing-Neal syndrome, you may need MRI and cerebrospinal CSF assay. And renal dysfunction could be because of amyloidosis or cryoglobulinic nephritis or light chain deposition disease or cause nephropathy. So there's a proteinuria, I think one should consider. So this is a picture from CSF showing lymphoplasmacytic cells, Bing-Neal syndrome. So differential diagnosis, because I was told to concentrate on diagnostic aspects, is going through some of the differential diagnosis. IgM-MGUS, myeloma, splenic marginal zone lymphoma, follicular lymphoma, mantle cell, marginal zone are the common differential diagnosis. One thing I would say in IgM-MGUS is less than 10% involvement in the marrow, and IgM paraprotein is less than 30 grams. Mid-88 is present in 30 to 60%, but it is CD19 negative. Usually they're asymptomatic or IgM related, and you don't have any other complications. My IgM myeloma is extremely rare, and it is negative for mid-88.
Time. So
okay, in 1 minute, I'll finish this. So these are the different differential diagnosis, but mid-88 will help in differentiating most of this. And this table shows you how to differentiate. Finally, our case, patient was symptomatic, so we offered plasma exchange, 3 sessions, and the protein dropped to 66 from 96, and her all symptoms markedly improved. And as a preface, we gave her cyclophosphamide, vincristine, prednisolone 1 cycle with rituximab for risk of IgM flare. Then we gave bortezomib, rituximab, and dex 4 cycles. She had an excellent response. The bone marrow cleared, and lymph nodes almost reduced to 1.5 centimeters. Paraprotein was, I think, 5 or 6 grams. So we continued another 4 cycles. It reduced to maximally to 1.9 grams per liter. We maintained her on rituximab for a total of 2 years in diagnosis, so she nearly got for 1.5 years. And she continued to remain well without any peripheral neuropathic symptoms. So 5 years later, her IgM is going up now, 6.3, but she's asymptomatic right now. And lymph nodes are small, less than 2 centimeters on PET. So she's currently under observation. We hope to do genomics, and depending on that, we'll consider further treatment when she becomes symptomatic. Thank you.
Thanks a lot, Dr. Imran, and sorry for interruption. It's just because of a matter of time. So we can share the diagnosis and the case with everybody, with you and Dr. Ramesh and Dr. Troen as a panelist. Dr. Troen, you want to comment on the case?
That's a very interesting case. Thank you for sharing with us. And I think it is important to keep in mind that 10 to 15% of patients, do present with cryoglobulinemia. Usually we see this mostly in, cold places like ours. So every January I would have patients very visibly, affected by their cryoglobulins. They would come in with, purple fingers, nose, ears, and, you knew right off the bat who you should be, looking at cryoglobulin levels. So I think, Imran very nicely touched upon distinguishing type 1 versus type 2 or 3 cryoglobulins, because this could, also impact on the reason why the patient is expressing cryoglobulinemia. Those that have type 2 or 3, you do want to do a workup to make sure that hepatitis C in particular isn't at the root cause. But I will tell you, we've done a lot of screening over the years, and it's extremely rare that you will see anything but type 1. The 7-day delay in leaving the sample refrigerated is important, because sometimes they will precipitate late and not early. So I do think, having this follow-up is very important. We also have had patients who behave like they have cryoglobulins. But even with refrigeration, we have not seen precipitation, but they'll come in with classic, Raynaud's symptoms. They'll be, having purplish purpura. So sometimes you can have thermoglobulins, which can, behave in the same way as cryoglobulins. So keep that at least in your differential in mind, when you're thinking about these kind of patients. I just also wanted to comment on the mid-88 testing. I think, you were clearly, getting there in terms of your workup. You would have liked that to help support your diagnosis. I think that is very important. But you did mention mast cells, and I want to at least get one word in that mast cells have helped us in the pre-molecular era to make the diagnosis of Waldenström, because they're very much intimately associated with the clone. They actually help support the growth and survival of the Waldenström cells. That was work that we published many years ago. And it's a very interesting microenvironmental effect. The Waldenström cells secrete soluble CD27 that binds to the mast cells. The mast cells in turn upregulate antigens like CD40 ligand and APRIL and others that help the clone grow and survive. And if you interrupt this, the Waldenström clones pass away. But you do see excess mast cells in about 70% of all Waldenström patients, and this has been traditionally how we've made the diagnosis. Now, of course, having the molecular diagnostics would help us even further.
Thank you.
Thanks a lot, Dr. Troen. So Pandita, do you have anything regarding your cases? Do you want to discuss any other issues for the second?
No, I think obviously it has been quite clear that we have moved on, that we need to have these molecular techniques available for a complete and a precise diagnosis, and also not only for diagnosis, for defining appropriate therapies. So CRCX4 mutational status as well as MYD88 mutational status is extremely important. Also important, I believe, is to realize that in younger patients, we don't use any therapy which is stem cell damaging. While in the older people, we might give a shorter therapies, but we could use some of those alkylating, though probably we will move on to ibrutinib. The only problem about getting to the newer therapies is the cost and indefinite treatment. So how do we address, is it by combining ibrutinib with venetoclax? You are looking at a CLL model of giving a time-bound therapy compared to currently advised or currently recommended therapy of indefinite therapy with BTK inhibitor, Professor Troen?
No, I think this is a great question, Ramesh, and we certainly don't have all the right answers here. But when you look at, how patients have done with BTK inhibitors, not only in terms of, response, but convenience, avoidance of secondary side effects, this becomes part of cost analytics. But to further address, means of containing cost, we are interested in this frontline study where we're giving 2 years of ibrutinib and venetoclax and then stopping to see whether or not this duration of therapy with combined therapy was sufficient to produce, long-term regression of disease. We have every reason to believe this may be the case because even looking at venetoclax alone, we've had such impressive bone marrow clearing of disease. This may be recognized. But in general, in the absence of such an approach, if you stop the BTK inhibitor later in the course of therapy, the patient will rebound. So this is why we do need to better understand if a BCL2 inhibitor will contribute to long-standing disease suppression.
And is the addition of a rituximab or a CD20 antibody, for example, in the INNOVATE trial, seems to relatively overcome some of these issues when you combine the two compared to ibrutinib alone?
Yeah.
So how much is the benefit of that? Because 6 cycles, if I'm not wrong, of rituximab and then indefinite ibrutinib anyway.
Yeah, no, it's a great question. I just wish we had that third arm, ibrutinib alone, because the INNOVATE study still left us with this open question of, do we really need Rituxan added? I think what INNOVATE proved to us is how active ibrutinib really is. But in the MYD88 mutated only population of patients, the long-term pivotal data is not that different. So I would not use it I would not add Rituxan to ibrutinib for a MYD88 only mutated patient. If they have both mutations and you're not in a rush to treat, it may actually bring the time to getting a major response to about the same level as somebody who doesn't have the CXCR4 mutation. So that may be the only kind of patient where I might add in the Rituxan. But otherwise, what INNOVATE I think really showed is how active ibrutinib really is.
Because the interesting phenomenon is in CLL, for example, the combination of ibrutinib plus rituximab was no different from ibrutinib itself. So
Right.
Is there biological difference between the two diseases?
Yeah, no, I think actually even from the Helios trial where we looked at, what ibrutinib and, what bendamustine and Rituxan added to ibrutinib, we saw very little difference. So these are both, diseases that tend to be very similar in terms of their behavior to therapeutics. And we certainly learn from one another, but you have to also keep in mind the mutations that drive things are also different. In CLL, it's a B cell receptor programming. In Waldenstrom's, it's toll receptor programming. There is intercept. They both intercept at BTK, but some of these fundamentals need to be considered, that these are genomically different diseases.
Thank you.
Can I ask one question if there is time, Dr. Amal? Or?
Yes, please. Yes.
Yeah.
Maybe.
Professor Troen, now that we have acalabrutinib as well as zanubrutinib from the ASPIRE showing activity in Waldenstrom's macroglobulinemia, hopefully they will receive approval soon. So how do you suggest, how should we choose these BTK inhibitors? From the ASPEN trial, it is very encouraging, especially the AF rates of zanubrutinib.
It's a great question. I think there's going to be a lot more variables that we need to consider. The convenience of therapy is the first one. Giving once a day ibrutinib versus twice a day acalabrutinib or zanubrutinib. And in the zanubrutinib trial, they actually migrated to twice daily because once daily was associated with more toxicity, as they showed in their blood paper that just got published. So I think the convenience, and with the convenience also comes the compliance of administration, also becomes part of the concern, especially in older patients, you know, where you might be concerned about somebody taking their drug twice a day. I think, you know, the experience, the longer experience with ibrutinib also should play into role here, because we now have, you know, an average of 6 months follow-up with longest study of ibrutinib and Waldenstrom's, you know, compared to 19 months in Aspen. So we may learn in time more, as we did too. You know, we used to think our AFib rate was 5% with ibrutinib, but going out, you know, we saw that it was 12% or 13%. So I think we need to keep that in mind. At some point, you know, cost is going to be an issue. I pray that Dr. You know, Pandita is right, that maybe with more BTK inhibitors, we'll see some costing considerations, but I don't see that happening in the United States, quite honestly. So that's less of a concern. The side effect profile, on the other hand, is a good one, because here we may act as doctors once again. You know, a patient that you might think might be at higher risk of AFib, maybe a history of paroxysmal AFib, you might want to prioritize zanubrutinib. But in somebody that have been, you know, previously treated and has, you know, cytopenias, you probably might want to avoid zanubrutinib. So I think there's going to be some decision making as we look at the different, you know, side effect profile.
Right. Thank you.
So we come to the end of our webinar. Still some question not answered. Probably Dr. Troen may type an answer for the participants. So really it was an excellent discussion, and a lot of things we learned from that. So thanks a lot for all our excellent eminent speakers. Thanks for our participants who joined us for the webinar, and special thank also for Janssen for supporting this series of webinars, and also another thank for our SSV technical support group, and looking forward seeing you again in our series of webinars. So thank you.
Thank you.
Thank you so
Thank
much
you.
for including me. Thank you. Take care, everybody.
Thanks a lot.
Thank you. Bye-bye.
Bye-bye.